Hello everyone, welcome back to my YouTube channel Dr.Barki's Ophthalmology Tutorials. Today we will continue with the surgical treatment options of presbyopia. So in this video I will be dealing with this monovision, which comes under lens based surgery, that is accommodating type, and also cornea based surgeries, which are nothing but non-accommodating type of presbyopic surgical management, which includes conductive keratoplasty, multifocal corneal ablation, corneal inlays, as well as keratophakia. Coming to monovision type of treatment for presbyopia. Here one eye, usually the dominant eye is corrected for the distance and the non-dominant eye is corrected for the near vision. So you can remember it as DDNN, where the dominant eye is corrected for the distance and the non-dominant eye is corrected for the near. Here usually we aim for achieving the difference of minus 1.25 to minus 2.5 diopters between the two eyes. Okay, but the preferred one is minus 0.5 to minus 1.5 diopter difference of myopia for the near vision. In that again we have two types, that is mini monovision as well as the blended. In the mini monovision again it is still reduced to minus 0.5 diopters to minus 0.75 diopters of myopia in the non-dominant eye to get the better near vision. In the blended it is at the higher end, that is to achieve minus 1 to minus 1 point diopter of myopia for the near vision. So advantages of having mini monovision is to have the target refraction of minus 0.5 to minus 0.75 diopter is it mildly compromises the distant vision. The stereopsis is well achieved and the intermediate zone is also having good vision. They are the advantages of mini monovision. We have something called as modified monovision, where we manipulate the spherical aberration to increase the near vision, but it will compromise the contrast sensitivity. So patients more than 40 years having mild myopia are ideal candidates for this mini monovision correction. And if the patient is having myopia of more than 4.5 diopter or hypermetrop, it's a contraindication for mini monovision. And if the patient is in 30s, again don't take them for monovision correction. And if the patient is having strabismus, phoria or the tropia, it will compromise the stereopsis still. So for the same reason, even the tennis players and the skiing players are also contraindicated for mini monovision type of treatment. So how you will know that the patient will be comfortable with the mini monovision post-operatively? For that reason, give a trial of lenses in the OPD only, or you can also use the contact lens and ask the patient to wear and be there in the OPD for some time and ask them how he feels about the vision. Then you can decide about whether to take the patient for mini monovision correction. And this correction may not be permanent, so the patient may need glass later. Now moving on to the cornea based surgeries, which are non-accommodating type. In that, the first we have the conductive keratoplasty. It is done for presbyopia on the non-dominant eye with the end point of achieving again minus 1 to minus 2 diopter of myopia. So this is considered when other invasive procedures for presbyopic corrections are contraindicated. Coming to the procedure, we have a fine conducting tip which will emit the radio frequency energy to the cornea. Once this fine tip is placed over the cornea and the energy is delivered, it will lead to non-ablative collagen shrinkage of the cornea, which will lead to denatured collagen, and thereby it creates a band of tightening as well as flattens the peripheral cornea, thereby increasing the relative curvature of the central cornea, leading to the final achievement of minus 1 to minus 2 diopter of myopic shift. So when you deliver the energy, this is how it looks with the conductive keratoplasty, and this is how the cornea gets altered. That is, there is flattening in the periphery of the cornea with a steepening of the central cornea, leading to minus 1 to minus 2 diopter of myopic shift, leading to better near vision. And this procedure is done under topical anesthesia, takes less than 5 minutes. The number and the location of the spots determine the amount of correction which is done. And between the spots there can be visible striae initially, which fades off over the time. But still, this procedure is not FDA approved for post-RK patients. Okay. So this is about conductive keratoplasty in brief. Now the second method is multifocal corneal ablation. Here we use the excimer laser, which can be done under different patterns, like small central steep zone ablation can be done, or there can be inferior near zone ablation, or inferiorly decentered hyperopic ablation, or central distance ablation with the intermediate and the near mid peripheral ablation. This is very superficial about the multifocal corneal ablation. This is just covered as a part of the presbyopic correction. Okay. Moving on to next treatment, that is the corneal inlays. Here the refractive error of the presbyopia is corrected by placing some preformed tissues or the synthetic material on or in the cornea. So this will alter the optical power by changing the shape of the anterior corneal surface. And the power of the cornea can also be changed by placing a lens with a higher index of refraction than that of the stroma. So inlays with a small aperture will use the pinhole effect and thereby increase the depth of focus. There was something called as keratoplasty, that is corneal tissue addition. It is not done nowadays due to poor predictability of the results. This corneal inlays can be used to correct aphakia and even the hypermetropia up to plus 20 diopters. But the complications are irregular lamellar resection, wound dehiscence, and there can be corneal edema. So this corneal inlays can be alloplastic corneal inlays. Here the synthetic material is used. This should be placed in the cornea. So if you place it over the cornea, the epithelial healing can be a problem. Here the hydrogel with or without the microperforation is the substance which is used. The index power of this hydrogel is similar to that of the stroma, but it changes the curvature of the cornea, thereby leading to myopia or even the multifocality. So these are the available alloplastic corneal inlays, that is camera or the cornea gen, where it has a small aperture inlay which is FDA approved, 5 micrometers thickness, biocompatible polymer, implanted in non-dominant eye of the patient, 3.8 millimeter diameter with 1.6 millimeter aperture in the center, placed at 200 micrometer depth of the cornea. Patient can get 3 lines improvement in the near vision. But the complications of this alloplastic corneal inlays are the instability with refraction, there can be decentration, corneal haze, and may need explantation sometimes. And one more type in the alloplastic corneal inlays are Presbyopia or the flexi view microlens. It is a small clear hydrophilic acrylic inlay. A pocket is created at the depth of 280 to 300 micrometers. Plano central zone for the distance, and the concentric rings will be there, and it gives additional power, therefore corrects both the intermediate as well as the near vision. This is about the corneal inlays in brief. So this was a very short video on the cornea based surgeries, that is conductive keratoplasty, multifocal corneal ablation, corneal inlays, and the keratophakia. I have not gone into the depth of these surgeries, but what to write when the question is asked about the surgical treatment of presbyopia, that part is covered in this video. And this video also includes the MONOVISION treatment for presbyopia. In the next video, we will see the recent advances or the newer modalities of treatment for presbyopia.